Ladies and gentlemen, welcome. My name's Julie McCrossan, and I really want to warmly welcome you to the first Beyond 5 webinar. It's all about head and neck cancer, and I want to begin as many people join us. We've got over 160 people registered. I'll tell you more about that in a moment, but people are literally flooding in as we speak. I want to begin by acknowledging that we're broadcasting on Aboriginal land. We're going to be meeting people from across Australia, so we're going to be on the land of many Indigenous people, and I'd like to acknowledge their elders past and present and pay my respects to them. Let me tell you as everybody comes in that, as I said, we've got over 160 people registered, roughly half patients and roughly half clinicians of all kinds. And we have people registered from everywhere in Australia, every state and territory, except the Northern Territory. So after we've finished and we've got it recorded and available on the Beyond 5 website, it's your duty to send it to someone in the Northern Territory to make sure that they all get to see it. We've got 10 family members and carers registered, and we have 30 current patients. So I think on behalf of everybody, I'd like to particularly welcome people who are dealing with the rigours of head and neck cancer treatment right now. My name's Julie, as I said, and I was treated for stage 4 oropharyngeal cancer in my tonsils, tongue and throat 7 years ago. And I'm a voluntary ambassador for Beyond 5, as are a number of other patients. We're going to be going for an hour and 15 minutes, and I will show you the program at various points. And if you have to come and go for professional or family or whatever reasons, it will be recorded and posted by Beyond 5, our host today, on their Facebook site and on their website. It'll be posted everywhere. The website is www.beyond5.org.au. So our purpose today is to provide you with education and support as people affected by head and neck cancer. You will be able to ask questions if you're watching us live on Zoom, if you know how to use the Q&A matter down there. We've already had quite a lot of questions coming in already. We've got a lovely man called Jackson with us up in the stratosphere somewhere, and if he could pop up the program for us, I'll just give you a sense of what we're going to do over the next hour and 15 minutes. In a moment, I'll be welcoming one of the Beyond 5 directors who has family experience of head and neck cancer. I'll then be welcoming Professor Richard Gallagher, Associate Professor Richard Gallagher, a working surgeon, who's going to give us an update on what COVID-19 means in terms of what is the key advice and information for people affected by head and neck cancer. We'll then have a briefing on immunotherapy. We'll hear about the impact of chemotherapy and radiation therapy potentially on our hearing and what we can do about it. And then we're going to finish up with a look at the value of music therapy and have some live performances. So that's our basic plan, and I'll love to introduce you at the end to Nadia Rosen, the CEO of Beyond 5, who will tell you where you can access the video recording of today. So the one other quick thing I want to say is that when it comes to questions, obviously we can't go into detail on personal detailed questions. If you have personal questions, obviously your doctor or members of your clinical team are best, but also if you're in Australia, Cancer Australia 13 11 20, I beg your pardon, Cancer Council Australia 13 11 20, they have trained clinicians who can answer all questions. And the one other thing I want to say is that we've also got international guests. We've got a big mob from New Zealand, our Kiwi mates across the ditch, and a welcome to you. But we've also got people from Ireland, the United Kingdom, and Bolivia. So welcome. So let's have our first speaker, and it's my pleasure to welcome Board Director Terry Gibson, a lawyer, a senior manager in legal services, and her cousin has been treated for head and neck cancer. So Terry, take it away.
Thank you, Julie. Good afternoon, everyone. I'm honoured to officially welcome you all on behalf of the Beyond 5 team. Every person who's joined any fight against cancer has a personal story to share. And it's these shared stories that allow us to feel closer to each other as we work together. My Beyond 5 story began last February when I joined the board as its first non-clinician director. The appointment came through a number of connections. I had personal friendships with other doctors, which is how I came to know Dr. Bruce Ashford, one of our clinician directors. And then last year, I lost my younger cousin, Jenny Brannigan, to head and neck cancer after a courageous battle involving 2 complete tongue reconstructions, and a battle which she carried out with astonishing strength and grace. Her amazing surgeons were Bruce and Professor Jonathan Clark. Poignantly, Jenny passed away on the 27th of July, which is World Head and Neck Cancer Day. So she made the end of her life purposeful, and in that made mine more so. For me, witnessing the complete arc of Jenny's illness affirmed my resolve to continue to help Beyond 5 by bringing this personal experience and my legal and risk management skills as a practicing solicitor to the board. So for me, being a part of the Beyond 5 mission is my way of honouring not only Jenny, but all head and neck cancer patients, carers, their family members and loved ones. Beyond 5 is a small charity, but we are growing across Australia and New Zealand and globally. And we now have an average of 2,000 visitors to our website each week. We are proud of our achievement, but we know we could and can, with more support, do even more. We rely on the voluntary support of many people, including healthcare professionals, patients and carers, to deliver reliable and trusted information to people affected by head and neck cancer, and to raise awareness of head and neck cancer in the general public, and for which we are very, very grateful. We also thank our community of supporters, including corporate partners and donors, whose contributions are key to ensuring the sustainability of our activities. A perfect example is the support of this webinar by an educational grant from Bristol Myers Squibb, for which we are extremely grateful, particularly during these unprecedented and challenging COVID times. I like to think of our Beyond 5 team as the Knights Templar of head and neck cancer. We are on a crusade with the firmly held belief that even though we are a small force, under the right conditions and with the best support, we can defeat this seemingly large enemy. With you, we can continue to make a difference. By working together, our mission is to put a spotlight on the disadvantage faced by many people with head and neck cancer, and to advocate for funding to support head and neck cancer prevention and patient care. I think the strength of our combined stories allows us to form a bond more powerful than just ourselves, and we won't be able to make a difference without all of you. Excuse me. So today, we are particularly thankful to all of our guests for giving their time so generously to join this, our inaugural webinar. We're delighted to be able to include speakers whose presentations at local support groups had been cancelled due to COVID-19, and to share them with a much wider audience. So we hope you enjoy the webinar and that it's fruitful for all of you. And thank you so very much for joining us today.
Thank you so much, Terry. And if I could say on behalf of us all, we're sorry that you lost your cousin. You know, I think one of the realities that we all live with if we've had a diagnosis like I have is that while Australia has some of the highest, if not the highest, survival rates in the world, once you've had a cancer diagnosis, you feel more at risk. And I think in these COVID-19 times, why it's so important to have this webinar is to not only to replace some of the face-to-face support group meetings that are no longer able to be held, but also to get that word out to people who may think they've got a problem or who currently have a diagnosis or are having follow-up, that it's absolutely critical to keep coming to see your doctor, to see your cancer centre and get the support you need. So I might bid you farewell, if I may, and welcome our second speaker, Associate Professor Richard Gallagher, who, as I mentioned at the beginning, is a head and neck cancer ENT surgeon. Director of the Head and Neck Service at the St Vincent's Health Network in Sydney and Director of Cancer Services. And Richard's going to talk to us about COVID-19 and what it means for people affected by head and neck cancer. Welcome to our webinar.
Thank you. Thanks, Julie. Thanks for having us. Thanks, Beyond 5. And
I love the surgical heads that I can see behind you, just to give you a sense of what's inside my skull. The purpose of this, I guess, is to have a real look at what COVID-19 means, both if you're in current treatment or you're in follow-ups care after treatment. Let's start with people who are currently patients. Will treatment be different? I know you're a working doctor. Will people have the same chance of survival and quality of life? And will their treatment be in any way different because of COVID-19?
Look, I think that if people are actively being treated at the present time, they should be being treated, and most centres, certainly here, we treat everyone, we're treating everyone pretty much the same as we were treating beforehand. So that should be the expectation. And there has been some suggestion that people might overseas, that they might have their treatment paradigm changed or the treatment options altered because of the worry about COVID. But certainly, I think in Australia, and I would also expect in New Zealand, that that's not the case, and that you will get what we would consider to be the best and most appropriate care. So it should not impact on your active treatment at the present time. It may change what it looks like when you turn up for treatment at a hospital, that you have your temperature tested when you come in the front door, that you're going to be asked multiple times whether you've recently had a cold or whether you've possibly travelled overseas. But it shouldn't, the experience, and there'll be less people around than normal at hospitals and at treatment centres, but essentially it should not impact on your treatment.
And so do the messages about keeping at 1.5 metres away from people, constantly washing your hands and wearing a mask, can you tell us your thoughts on all of those as a patient or family member in active treatment?
Yeah. Certainly. So the social distancing rules are very important, actually, and they need to be upheld because it's probably one of the most important things. When we talk about 1.5 metres, it needs to be sort of 6 feet or 10 feet. So around that, if someone coughs or sneezes, in fact, those particles float through the air for really many metres, in fact, rather than just a couple of feet. So the social distancing is important. So if you turn up to your treatment centre and you're told, well, look, you've got to sit in every third chair or fourth chair, we're doing it for a good reason. It's to care for you, the patient. The other things that happen having your temperature checked when you come in is important. The social distancing is important. I think it's important that if you know that you are unwell or that you potentially do have a cold or a respiratory tract infection, that you declare it before you actually come to the hospital, or you declare it to your doctors or your cancer care coordinator that you might be unwell, that you might need to have a test before you come to the hospital. Because that's the one thing that would make a very big difference to your treatment, is if you became COVID positive during treatment.
You tell me what, so I was just thinking as I was listening to you, Richard, I've got my little hand sanitizer here.
That's right.
Constantly using it. But if I am unlucky enough, this thing's highly infectious, I'm in treatment and I get COVID-19, what does it mean?
Well, I mean, that is going to impact on your treatment. I mean, it means that we have to seriously consider whether to treat you with chemotherapy would be a really important thing. Radiotherapy can certainly occur. Again, it has some impact on your immune function, but really chemotherapy or immunotherapy, I think that the medical oncologists I know would be very reluctant to give any active treatment, because the risk of converting someone who's got a possibly minor illness into someone who's going to end up on a ventilator or in an intensive care unit is just too high. mean, one of the big problems is about any of these things is the use of the PPE or the personal protective masks and gowns and things like that, that hospitals have, they have a good supply of, but in fact, they're really quite limited and they would run out after a relatively short period of time. So that's why it's important if we do the things that you're talking about, social distancing, washing our hands, using hand sanitizers and things, that will help keep COVID at bay and hopefully prevent people being in that situation that you've just mentioned.
So your number one goal is to avoid getting it.
Yeah.
But what I often say to my friends who ask me, because I've had cancer myself, is that you guys, you multidisciplinary team people, if a person urgently needs cancer treatment, you're going to get it to them in some way or other, adapting to the circumstances. But we've got to make our contribution by trying to do all the social distancing, the hand washing.
Yeah, we do. I suppose I should just touch on the mask issue. You asked about masks. It's not that the recommendation at the present time, really still from the health departments across Australia, is that you don't require a mask. Now, I think there are some situations where you would think carefully about it. That is, if you were someone who had an active infection and you had to turn up to the hospital, you should wear a mask or should ask for a mask when you turn up. But otherwise, for the rest of us, really, there's no good evidence about it. I know it's happening around the world, but it's still not clear that it's actually that helpful, except in those situations where you're dealing with someone who's actively infected, or if you, as a doctor or as a patient, may have symptoms that you want to protect other people from.
We've got a number of questions coming in, but I just want to quickly say one more thing about the mask. If I'm a family member, we've got a number of family members and quite a few professionals listening to this. If I was a family member, would I keep a mask on would there be any merit in that when I'm in close daily contact with the person I love who's in active treatment?
No, there is no, unless you have symptoms, and that's why, I think in those situations where people are going to be concerned, you test your temperature every day. You make sure that you couldn't possibly be carrying, being unwell. But no, it is not necessary to wear a mask in that situation, not unless you're unwell.
Just a question has come through in relation to someone in current treatment. Will the COVID-19, if I got it, affect my other medications, if I'm on existing medications?
Do you mean your normal treatment medications for other illnesses?
Could be, that's the question that's come through.
No, the answer is that you should stay on all other medications. I mean, it's only if you are potentially on some immunosuppressive medications for other things like rheumatoid arthritis, where you would have to, that discussion does need to be had with those doctors who look after those problems about whether you discontinue that immunosuppressive treatment. But all other treatments, like treatment for diabetes or cardiac disease or for lung disease, you need to stay on, because we know that the people one of the groups who are at highest risk are patients who've got those problems. And I mean, a lot of patients with head and neck cancer have been smokers or are smokers. That puts you at a higher risk. So it's important that you stay on your treatment.
Just before I go on to patients who've had their treatment but who are coming back for further support, Yvonne from South Australia has sent you a message to say she loves the surgical models that you can see behind you, and she feels she now understands where her cancer was. So I just thought I'd let you know. Look, my next question is, if you have finished your treatment but you're coming in for follow-up appointments, or I know I had three monthly, then 6 monthly follow-ups where a scope went down my nose to check for recurrence. If people have had surgery, they may be having wound care. Does any of that change because of COVID-19, that follow-up stuff?
No, I think COVID-19 impacts in different ways. I think firstly, I would say that there has to be ongoing follow-up. It's a matter of what form that follow-up takes. I think that continuity of care And you touched on it briefly just before about people being reluctant to come into hospital or maybe being delayed with diagnosis, which maybe you can touch on later, which is a very real concern of mine and my colleagues. And I think everybody who's involved with patients who have cancer. But from the point of view of your ongoing care, that continuity of care and ongoing journey is really important. I think where it can change and where it may alter is, for instance, if you had, if you're from the, particularly, I think if you're from the regions and you've had something where it's an external problem, maybe you've just had to have a skin cancer excised or you've had a neck dissection, but nothing inside your throat or inside your nose that needs to be looked at. Possibly we can do that, and I've done that with patients with using a platform, you know, not dissimilar to Zoom, called PEXIP, which is what the New South Wales State Government uses, to do a video consultation with them so that I can look at their wounds. And I've done a couple of those, and I've done it at doctors' surgeries with a doctor or their nurse practitioner being present. But for people who have had a cancer down their throat, I think, you know, I'm afraid, you know, you need to come and need to be scoped. Now, there has been a lot of reluctance by a lot of people to potentially scope patients. I think that's of concern to me, but that might be a problem for people.
Can I just tell you, Richard, that is one of the questions. We've just got 4 minutes left, and I've got a few questions, and one of them was, is it okay to keep using that scope that goes down the nostril to see the cancer down here during COVID-19?
Absolutely, as long as the appropriate cleaning of the scope is done. So because the questions are, you know, COVID there are high loads of COVID in the nasopharynx and the oropharynx and nose. So you're passing the scope through that area. As long as the scope is being cleaned appropriately and being looked after, that makes it safe for the patient. And then the second thing is it's safe for the practitioner, which means that patients come in, you know, you have your temperature tested, you're asked the questions, and as long as you're well, you should proceed on, and there should be no problems being scoped.
Should I download the COVID Safe App? That's one of the questions.
Yeah, I'm very supportive of doing that. I think that it potentially is going to help. It will certainly help individuals and the rest of the population if we can easily trace people. So I think it's definitely worth doing. It makes a lot of sense.
I'll just say for our international viewers that the Australian government has asked all Australians to download onto our phones an app that records the contacts that we have, so that if we're diagnosed with COVID-19, it helps what they're calling the detective tracers or something, but
yes.
It helps the people tracing our contacts. And so that's what that's referring to. Another question, if I'm in treatment or I'm recovering from treatment, should I get the flu vaccine?
Yeah, absolutely. I think that that's a really important thing. I think anybody who's had head and neck cancer should certainly get the flu vaccine. If you're in treatment, you've got to be careful. You've got to discuss it with, particularly if you're having drugs. So if you're having chemotherapy, immunotherapy, you'd have to have that discussion with your medical oncologist. But if you've just finished treatment, definitely you should have the flu vaccine. I think we would all be in agreement about that.
I want to say that we've had a message from Denise on the Central Coast of New South Wales, thanking you for all your helpful information so far. But I want to get 2 more bits from you if I can.
Yes.
One person has contacted us to say, what are your thoughts on hyperbaric oxygen therapy? Can you do a 1.5 minutes on what it is and whether it's useful?
Okay, so hyperbaric oxygen therapy is the easiest way to think about this is it's a way of getting a high dose of oxygen into the body. So most typically hyperbaric oxygen has been used for treatment of the bends, a problem that develops in divers when they come to the surface too quickly. So that's where it's usually associated with the Navy and divers. However, it's used in medicine and surgery to get increased oxygen flow into the tissues. The problem for head and neck cancer patients is that if they have radiotherapy treatment, that they are set up potentially to develop a problem called radionecrosis. where you get tissue death, which is tied up with loss of blood supply. And if there's loss of blood supply, there's loss of oxygenation. And if there's loss of oxygenation, it means tissue can die or not heal. So the idea behind, the concept behind hyperbaric oxygen is to increase or to force increased amounts of oxygen into the body, into the blood and into those tissues in a very simple concept. It probably has a role in certain areas. It's not clear. There is not great evidence to show that it helps. And I do think that people get idiosyncratic reactions. So some people will get benefit, other people won't get benefit.
Okay, thank you. So it's one of those ones where there's a bit of an open discussion.
Yep.
We've had someone come in from South Australia to say she's had 36 sessions of hyperbaric oxygen and feels it was useful. Look,
yes.
our time is up, Richard Gallagher, but I just want to say that final message about the drop in attendance at cancer doctors to get checked. What's the important message that the professionals and the patients who are watching us today need to get out to the community?
I think it's important that we've got to make people realise that if you notice something is wrong, you still need to present. You still need to go and see your GP. If you get a neck lump, go and see you have to make contact with your general practitioner, and they should refer you on. There is no reason not to. You should not be afraid of coming to a cancer centre. You shouldn't be afraid of coming to the hospital or to see a specialist. That's my big fear, is that there are people who are reluctant to attend. It's a scary concept, COVID, but we're lucky. We're in a lucky country, and New Zealand are lucky as well. We've got very small numbers of cases, and fortunately, we're not facing the same problems necessarily as overseas. So that should reassure people as well. And health services are taking it very seriously, as is the government, which is different to, say, the United States, where initially it wasn't.
Well, look, Associate Professor Richard Gallagher, ENT surgeon and Head of Cancer Services at St Vincent's Health Network in Sydney, thank you so much for being part of Beyond Five's first webinar and for having such interesting things behind you. We're enjoying those images.
Okay,
so
well, thanks for having me. Thank you. Bye. Goodbye, everyone. Thank you.
And ladies and gentlemen, if you've just joined us, this is the first webinar that Beyond Five has run, and we've got a number of speakers. If I could introduce to the screen Dr. Amy Pereira, I'll let you know who she is. She's been listening in to Richard as he speaks. Our third speaker is a medical oncologist from the Kinghorn Cancer Centre, and I think Amy is going to join us any moment. We're probably just trying to get her up, but I'll still let you know about her. I know I can hear you, but I can't yet see you. And maybe Jackson can help us there. Unless Richard is secretly Amy Pereira by another name, because he's from Darlinghurst in Sydney. That's a small joke. Amy's a medical oncologist with the Kinghorn Cancer Centre, and she specialises in early drug development and head and neck malignancies. And she's going to talk to us about immunotherapy. Jackson, if I'm not able to transfer over to Amy, is there someone else? Am I able to transfer over to Cathy Holland, if you're able to tell us? This is the wonders of live broadcasting. We now do have Cathy Holland, who's a senior audiologist in Adelaide at the Flinders Medical Centre. If it's all right with Amy, if you could hang loose, we will sort out the technical problems and come back to you in a moment. So if you've just joined us, this is a head and neck cancer webinar hosted by Beyond Five, and we're offering information and support to people affected by head and neck cancer. Roughly half the people who are with us are professionals, and roughly half are patients and family. And we have about 30 patients who are currently receiving treatment. And our next speaker is going to be Cathy Holland. As I mentioned, she's a senior audiologist at Flinders Medical Centre in Adelaide, and peeking off to the side, if you can lean in, Tracy, so we can see you, is Tracy Nichols, who's an ear, nose and throat nurse practitioner in South Australia. She's the coordinator for head and neck cancer in SA Health and a great advocate for patients, and we welcome you, and it's great to see you there as well. So, Cathy, you're going to tell us a little bit about the impact that chemotherapy and radiation therapy can have on hearing. So take it away and we'll have questions for you at the end.
Okay, thank you. I'm just going to share my screen so that you can see. Okay, so I'm going to be talking, as Julie said, about the effects of chemotherapy and radiotherapy potentially on hearing. And I'd first like to thank the organizers for including what we feel is such an important but unfortunately overlooked aspect of care and sometimes not recognized. So I'll be talking about both the effects and also perhaps most importantly, what can you do if you're noticing changes in your hearing. Should just be. So first, I will talk about what we call an autotoxic medication. So autotoxic means it's something that is potentially toxic or poisonous to the ear. And there are over 200 medications on the market that are considered ototoxic. There are two main groups of drugs that are ototoxic, and one big group are chemotherapy drugs. And then there are some antibiotics that are also considered ototoxic. This might mean that it can affect your hearing. It might affect tinnitus, which is ringing or noises in your ears. And it might also affect balance as well, because your inner ear is also where your balance system lies. And unfortunately, it's important to know that if there is damage to the ear as a result of chemotherapy, it is often permanent, and that's something that people find quite surprising and have been unaware of, and often they even come to us for the hearing test, and we say, do you know why you're here? And they have no idea and haven't heard of this as a possible outcome. So one of the things you might ask is, well, if we know it causes permanent hearing loss, then why are we using these drugs? And the answer is that sometimes there's little choice. The drug may be one of the only known treatments or thought of as the most effective treatment for a particular cancer. And that's why it's been chosen. Now, as to whether the chemotherapy will affect your hearing, it very much depends on the drug. And the two big drugs that we receive referrals for are cisplatin and carboplatin. And as you can see, the cisplatin can have a really very high incidence of hearing loss that results from the treatment. It's one of the most widely used drugs for many different cancers, and that is because it is a very effective drug. Unfortunately, though, it can't specifically just target the cancer, and because you have this drug in your system and in the blood, it can get to the ear and collect in the ear and can cause hearing loss. Now, I think it's important to know that when I say it can cause hearing loss, it doesn't mean that someone will have a treatment and will wake up with no hearing. It usually affects hearing in the very high frequencies or high pitches before it spreads and starts to affect pitches that really contribute to understanding of speech. So we're quite fortunate here at Flinders Medical Center. We have equipment that can test out to really high frequencies and higher than what we standardly test and higher than pitches that contribute to understanding of speech. And what we look to do is identify any changes before you might notice them. Now, I said, I'm just going to grab this. So I said that with chemotherapy, so there are 3 different parts to the ear. So you've got the outer ear, which leads the ear canal up to the eardrum. Then the middle part of the ear, which has the little bones of hearing. That also has a tube, the eustachian tube, that runs down to the back of your throat. That's when you yawn and might pop your ears, lets air get in and helps keep everything working well. And then we have the inner part of the ear, which contains the balance system and the hearing system, and it leads to the hearing nerve. Now, the chemotherapy tends to affect the inner part of the ear. Radiotherapy can affect the inner ear and the hearing nerve, but depending on the type of cancer you have and where the radiotherapy is directed, it can cause irritation and swelling, and can affect the ear canal. If there's radiation in the throat, it might affect this eustachian tube and how well that works, and then that can cause a temporary hearing loss. And so often those effects can be treated or will resolve with time. The other thing with the radiotherapy is that that's kind of a newer area, and if hearing loss that's permanent occurs, sometimes that might not occur until 6, 12, or 24 months down the track. So we do monitor hearing much longer when it comes to radiotherapy. You don't have to come in every other week, but we might see you a few times early on, and then at 12 months, 24 months, and we actually go up to 36 months here. So a few things that might increase your risk of hearing loss: the dosage of the medication, the number of treatments that are required, the combination of chemotherapy and radiotherapy. Now, those first 3 factors are something that your treating doctors are always weighing up. They're looking at the risks versus the benefits of the treatment, and that's something that they're weighing up and looking at any side effects as you move along in your treatment. And things might change, and they might reconsider exactly what you need. The 4th thing that often people are unaware of is noise exposure during treatment. Now, that's high levels of noise, industrial type noise, use of power tools. So, if you're in the midst of treatment, but you're having a good day, you feel well, and you want to go out in the shed and start using your power tools, you really need to think twice about that. You should be using hearing protection in any case, but it's particularly important when you're undergoing treatment, because the combined effects of the chemotherapy and the noise can have a much higher risk of causing damage. So when should your hearing be tested? Ideally, a baseline test before treatment. If you already have some level of hearing loss, it's important to know where you stand before you start treatment, and then we can look and we can tell if there are changes. Sometimes we get a referral and people will, the referral will say, hearing loss following treatment, let us know if hearing has changed. Well, if we don't have a baseline test, we don't know. With chemotherapy, we monitor before each cycle. With radiotherapy, it's after the treatment. Again, this is ideal world. People sometimes aren't well enough to attend appointments. Sometimes treatment needs to start before testing can be organized, and unfortunately, not all clinics have access to audiology services readily. So that's certainly another factor. What if your hearing does change. What if we detect changes? What does that mean? Does that mean you can't have treatment? No, it means that our role as audiologists is to keep you informed, to keep your treating doctors informed. So as I said before, they can constantly be weighing up the risks and the benefits of the treatment, maybe they decide they won't give you one big dose of treatment, they'll spread it out over a few more smaller doses. In any case, it's always really important that any decisions are made in consultation with your treating doctor, and looking at the risks.
Cathy, could I just say we've got 2 or 3 questions, so if you were able to wrap up, your time is almost up.
Sure, I've just got 2 more. So what can you do? As I said before, you might not have ready access to an audiologist. And even if you do, it's always important to let your doctor know if you notice any of these changes, noises in your ears, fullness or pressure, speech sounding unclear. As I said before, the hearing, it doesn't just go. You might just start to find that things are muffled and not sounding the way they should. Dizziness. So let your doctor know if you are experiencing any of those things. And finally, things to remember. Hearing monitoring, it varies between different clinics. Always tell your doctor of any concerns. And most importantly, there are things that can be done. So there are hearing aids, there are other devices. We can help patients with strategies for themselves, for their family, and the same with tinnitus. That's often very distressing, but we can help with strategies for tinnitus. And once again, stressing, avoid noise exposure during your treatment.
Well, Cathy Holland, thank you so much. If you've just joined us, Cathy is a senior audiologist at the Flinders Medical Centre in Adelaide. And I've just got a couple of questions. I'm going to ask one myself first, if I may. As I am 7 years out of treatment with radiation therapy and cisplatin, and I've had quite a significant amount of hearing loss, but I'm also alive. And because I'm on quite a number of patient Facebook groups internationally, I know some people question, well, should I have cisplatin in case I have this poor side effect? And I guess, what's your message to people? Because speaking personally, I'd rather be alive, and I expect to get hearing aids earlier than my mother did. I'm 65 now, and I expect to have them not too long away. But I'd rather have hearing aids and be alive than not be alive.
Well, again, as I said before, it's really, these are decisions that you need to make in consultation with your treating doctors. And when the treatment is potentially life-saving, then people generally are willing to take that risk. So, you know, it's important to be aware that the hearing may change, but if the treatment is curative or going to extend your life significantly, then you really need to look at the benefits versus the risk, and also just realize that there are options for you. If the hearing does change, there are options.
And just to come to that advice in your last list, this notion of a baseline test, that even if you're at a cancer centre where it isn't raised with you, there isn't an audiologist on the team, get your GP to refer you to an audiologist and have a hearing test so you know what it was before the impact of the treatment. Is that the basic idea?
Exactly. So, I mean, if the clinic is lucky enough to have equipment as we do that you can test out to the really extended high frequencies, that's the best case scenario. But I would certainly rather have a standard hearing test and have something to go on in case the person comes back down the track saying, I think my hearing has changed. We can tell you where your hearing is, but we can't tell you how much it's changed if we don't have anything to compare it to. My
final question is again, just to reinforce the point about tinnitus. I too experience tinnitus at a manageable level, but I know many fellow head and neck cancer patients who do get distressed. Just in a nutshell, what is tinnitus, and 2 or 3 tips for living with it?
So tinnitus is certainly, it's very real. Sometimes people think you're telling them that, well, it's just in your head. It's a very real thing. We don't always know exactly the mechanism that causes the tinnitus, but
So it's like a funny sound inside your head and sometimes a sensation.
It can be a ringing, it can be a buzzing, it can be a bell clanging. People will describe it in many different ways, a hissing sound. One of the things we do know about it is similar to pain, that the more someone focuses on it, the more it heightens your annoyance, the worse it gets. And so many of the treatments with tinnitus, one thing that can help is a hearing aid, because sometimes the absence of useful sound makes the tinnitus worse. So if there's also a hearing loss, treating the hearing loss can help. But it's also really helpful to learn techniques to relax, to move your focus away from the tinnitus. So again, that's not saying the tinnitus doesn't exist, but it's trying to help turn your focus away from it. I have a clock sometimes in my office that when I stop and think about it, it ticks really loudly. And I think that is annoying me, but generally I don't notice it. And it's a similar thing. You know, once you focus on something and think that is annoying me, then it gets louder.
Look, can I just say on behalf of everybody, Cathy, how fantastic it has been to be informed about this issue of hearing loss, which in the cut and thrust of surviving head and neck cancer, we don't always hear about it beforehand. And indeed, one of our, someone called Sue has contacted us to say what excellent advice this is, that she's about to start treatment and she intends to take it. And so we need to finish now, but thank you so much to Cathy Holland, Senior Audiologist at Flinders Medical Centre in Adelaide. We love South Australia, and we just love to see just that lurking moment of a nurse in the background, Tracy Nichols, who's the statewide coordinator of head and neck cancer and a great advocate, and it's wonderful to see you there as well.
Thank you very much.
Thank you. See you later, South Australia. We're going to come back now to New South Wales, and we're joining Dr. Amy Prawira. We had a little bit of trouble earlier, but I'm hoping you're going to pop up on my screen in a minute. Yes, hello, welcome. And if you can unmute yourself or someone will. Are you there? Can I hear you, Amy?
Yes, I am.
Ah, fantastic. Well, Amy is a medical oncologist at the Kinghorn Cancer Centre in Sydney. That's in a street called Victoria Street in Darlinghurst, where there are many health services, including the St Vincent's campus. And Amy specialises, or Dr. Amy Prawira, I should say, because people often say that you're more comfortable calling female doctors by their first name, and I mustn't fall into this trap. But that you specialise in early drug development and head and neck malignancies. And you're going to talk to us about immunotherapy. Just before you begin, and we've already got some questions as well, but I'll let you do your presentation. But do you want to comment on the tinnitus? Because as a medical oncologist, you must give some of the medications that lead to tinnitus. Any of your comments you'd make there?
Absolutely. I think our audiologist colleagues are extremely valuable. As a standard, I do test my patients' baseline hearing before we commence chemotherapy, and it is one of the decision-making factors in terms of determining the dose and the schedule, especially when it comes to curative intent chemoradiotherapy. And I am acutely aware of the long-term side effects that our treatment do have. It is one of the hardest, if not the hardest treatment we have for cancer. Even though it's curative in intent, you know, our patients have to live with the side effects for a long time. So whilst I do not have a clear answer for it, I just think that it is an important problem. There is actually a new study that looked at decreasing the effects of cisplatin on hearing, but that has only been researched in the pediatric population. So I'm hoping that in the future we might see that in the adult population too.
Well, thank you. If you could introduce immunotherapy, we have about 30 people who are currently in treatment with us, and quite a large group of people who are post-treatment, and roughly half the people with us are clinicians of literally every kind, just to give you a sense of the audience. So what is immunotherapy and what do we need to know about it?
All right, so I'm just going to share my screen here and I'll see if it works.
Yes, it's looking good.
Yeah, so I'm just going to keep the introductions brief, and I'd like to hear more about what you would like to know, particularly about immunotherapy. So I just want to give a very brief background on the most common immunotherapy agent we have today in head and neck cancer. So in general, this is actually a diagram that is on the Beyond 5 website. It's under emerging therapies and immunotherapy. So in general, our cells, they have antennas or so-called protein receptors on their surface. The cells make these antennas using the DNA as the code. Cancer cells, because they are genetically abnormal, they have an abnormal code. So they also theoretically would make abnormal looking antennas. Our immune cells are actually geared to attack anything that looks abnormal or foreign to us. So by right, they should be able to see the cancer cells as abnormal, right? They have all these blobs, and they should be able to kill them like this. So this is a normal way, immune cells recognizing the cancer cells and killing them. But one of the ways that cancer cells have become clever or avoided killing is by giving up this little so-called white flag that says, don't kill me, I'm a friend. And that's what we call an immune checkpoint. So the most common immunotherapy we have today, and also the one that's been approved by PBS in head and neck cancer, actually stop this, gets rid of the white flag interaction so that it would allow the normal killing of the tumor cells by the immune cells. I'll give it back to you, Julie.
Thank you. Do you want me to ask you a question?
Yes, I'm happy. I can keep talking, or
Oh no, you say what you want to say first. Thank you.
Yeah, so I think there has been a lot of hype around immunotherapy. Some of them are founded, a couple of them unfounded. It has given hope. I think the first immunotherapy approval was the first drug that was approved in more than 10 years in head and neck cancer. So finally, we're seeing something that has some activity. But I think part of the hype is that it doesn't work for everybody, unfortunately. So there are
Dr. Pereira, because I know we've got some people who are totally new to this world of head and neck cancer, I might just ask you a question. So I was treated for stage 4 cancer in my tonsils, tongue and throat 7 years ago. And I've been very fortunate in that while I have some side effects, I'm basically well and able to work. I can talk and I can eat, And I guess in my heart, I think if I should get recurrence, and I've been checked a lot over those 7 years, one of my hopes could be immunotherapy. I think that's how a lot of patients think. So I guess my question is, when are people offered it? Who's eligible for it? How do you get access to it? And how much does it cost?
So I'm going to start with what's currently funded by PBS. So there are two different sort of treatment aims, so-called. So the first is curative intent treatment, and that's when we try to get rid of the cancer and prevent it from ever coming back. The second is what we call palliative, and these are usually in the settings where the cancer has come back or it has spread to other organs, where the aim is to try to control the cancer as much as we can, so people can live a good quality of life, because having cancer in your body can give you uncomfortable symptoms. And in addition to that, we're hoping to help patients live for as long as they can. So currently, immunotherapy is funded by Medicare, and you can obtain it, obviously under Medicare in what we call a palliative setting. So that means if the disease is incurable. And currently, it is only funded under Medicare once the cancer has become resistant to chemotherapy. So what it means is this: cancers, when it becomes incurable, can evolve, unfortunately, if you think about it, like bacteria become resistant to antibiotics. So that if you give one treatment, after a period of time, the cancer will develop resistance to it. Now, so what happens here is the first line treatment is chemotherapy under PBS. And if the cancer got clever to that, then the immunotherapy will be funded. There are some exceptions, but I won't go into that detail.
And I'll just say for people, if I may, listening, that PBS stands for the Pharmaceutical Benefits Scheme. We have some international people with us, and that's the Australian government's way of paying for our medication or making it cheap enough that everyone can afford it. Sorry, but go on.
Thank you for that explanation, and thank you for covering that. Yeah, so the other part is where we're at in terms of the research and where things are at with immunotherapy. So in the setting of incurable disease, where the treatment intent is palliative, as I mentioned before, there is actually now new evidence where if we give immunotherapy with chemotherapy, as soon as we find the disease to be incurable, might be advantageous if there are certain markers on the cancer surface. The other part is giving immunotherapy early on, so that's in the curative intent setting. And it has been looked at as well in patients before they go on to surgery and afterwards, either before surgery, after surgery, or after chemotherapy and radiation. There are also studies that looked at giving immunotherapy together with chemotherapy and radiation. At the moment, as far as I'm aware, the results are mainly for safety, so that it is possible to do so without adding too much toxicity. But the long-term outcome, whether it actually benefits survival, is still yet to be fully known.
And Dr. Pereira, does that mean that if you are wanting to find out whether immunotherapy could help you, that seeing if there are any clinical trials where you may be able to get access to it, you may qualify, may be one of the ways your doctor could help you try that treatment?
Yes, absolutely. So, and that's actually the primary driving force why we do clinical trials here at the Kinghorn. Because often the clinical trials that we choose to run allows patients access to new treatment that has been shown to be effective before they receive government funding through Medicare and PBS. And we do have such a clinical trial for what we call first-line immunotherapy in head and neck cancer patients running, and that's the reason, because it is not currently funded by Medicare, and that's one of the ways we can access it.
Our time is almost up, but I want to ask you 4 quick questions that we've got, if that's okay. The first is, if you have got access to immunotherapy treatment, are there side effects? And also, are there some people for whom it does not work or help?
Yes, so in fact, immunotherapy, the one that I was talking to you about, the single agent, when given on its own, immunotherapy alone, doesn't work for everybody. In fact, it only works for about less than 1 in 5 of patients. So that's why sometimes chemotherapy still has a role, because the chances of chemotherapy working is actually higher, but the duration at which the chemotherapy, if it works, it doesn't halt the cancer for very long. The immunotherapy tend to halt the cancer for longer when it works. And in terms of side effects that you're asking, the majority of patients actually do not have side effects from immunotherapy. But because we're getting rid of these white flags that I was talking to you about, that protects the tumor cells from the immune cells, our normal cells also use it to protect themselves against any rogue white blood cells that we may have. So the chances are, if someone has the so-called rogue white blood cells, they may start having their immune system attack their normal cells.
Another question, you talked earlier about the difference between curative treatment and palliative treatment. And I just wanted to go to that question of palliative, because I think for a lot of people, they think of it right at the end of life, like only even days or perhaps weeks. Whereas it's my understanding that if you're lucky and a treatment is palliative, sometimes it might give you quite an extended period of life.
Yes, exactly. I'm going to bring forward another concept called the median, because the numbers that's often quoted in terms of how long will the disease be controlled for and how long will I live, it's actually the median. So that means we would be, if you think about it, it will be like, putting patients from the ones who live the shortest and the one who lives the longest, taking patient number 50, out of 100 patients, and that's the number that we quote. That means 50% of the time people live longer, but 50% of the time people do live shorter. So you're right, it is no longer a full, so-called short life sentence, but it is a serious disease, and there are some patients in whom the disease is so resistant to treatment and can be very aggressive.
Look, unfortunately, our time is up, but there's one last question I want to bring you because it's come from a research student who's watching us now. Excuse me. And they say, where would you, doctor, like to see the focus placed in terms of local research?
Yeah, so that's a very good question. And I guess I just wanted to come back because I can see the question here. The problem is the research that the person's doing is cutaneous, so skin, head and neck cancer. They are a bit different to the head and neck cancer that comes in the mouth and in the airways. And the research has a slightly different focus too. I think in terms of where I would like to see the focus is, we need to improve the proportion of patients that benefit from our treatment. Just because immunotherapy, when it works, it's great, but it doesn't work for enough patients. We need to find a way to make it work for the majority, if not all of our patients. That's what I would really like to see.
What a pleasure it's been to have you on our Beyond 5 first webinar on head and neck cancer. Thank you so much.
Thank you for having me, and thank you, the Beyond 5 team, for organizing.
Thank you. Dr. Amy Pereira, medical oncologist at the Kinghorn Cancer Centre, which is in Sydney. And ladies and gentlemen, we've just got approximately 15 minutes left. If you've just joined us, this is the first ever Beyond 5 webinar. And as we move over to welcome Dr. Emma O'Brien from the Royal Melbourne Hospital, and I think our friend Jackson will be getting her up on the screen, I want to say to people, here she is, I'll just be one moment, Emma. I just want to say to people, if you have any questions that are pertinent to you, that are troubling you, of course you can talk to your own doctor or clinical team. But if you're in Australia, Cancer Council Australia has an information and support line called 13 11 20, 13 11 20, and they have trained clinicians there who can answer your questions, or they'll go and find the answer. So please consider doing that. But let's come back now to the Royal Melbourne Hospital. We've travelled to Victoria, where it's probably a bit chilly today, I think. And Dr. Emma O'Brien, OAM, is a music therapy fellow. She has a PhD in guided songwriting with cancer patients. And Emma, I wondered before I ask you some questions about music therapy, we've been listening to talk for a long time. Could you introduce a song and sing it for us, and then I'll ask you questions?
I'd love to, Julie. I'm going to actually sing a song written by a young girl who was living with cancer. So a lot of the work that we do at the Royal Melbourne is in songwriting, and also at Chris O'Brien, where I'm the fellow as well. And we picked this song. I was having a chat to Nadia, and we picked it because her song's all about isolation. And I know that's something we've all got in common at the moment. It's got a bit of humour in it. It's a little bit funky. It has a lovely chorus that repeats "everything will change." I'm sure you'll be able to pick up on that. And I think it seemed like a relevant song, and it's amazing. I wrote this song with her in the special method I think it's about 19 years ago. So it's still standing up as a classic, Julie. Every day it's the same thing, it's the same routine again. You get up in the morning, it's the same, but the shower is such a highlight. Then you know who's gonna come in. It's the nurse, the cleaner, the doctor, the girl who changes my plastic bag bin. Although it's the same, it's one more day up on the wall, one more day closer to leaving this all. Then things, they won't be the same. Life will be better and everything will change. Every day it's the same thing, it's the same routine again. I got up this morning and guess what? It was the same, but the shower was such a highlight. And then they all came in. It was the nurse, the cleaner, the doctor, the girl who changes my plastic bag bin. But soon everything will change and nothing will be the same. Soon everything will change and I'll go on living again. I'll have friends, family, home, sunlight, fresh air, stormy weather. Friends, family, home, sunlight, fresh air, stormy weather. Probably enjoyed this bit. Everything will change. Everything will change. Everything will change. Everything will change, and soon everything will change and nothing will be the same. Soon everything will change and I'll go on living again.
Woo! This is clapping for people who are deaf. We've just been talking to an audiologist.
Yeah.
If you've just joined us, this is Dr. Emma O'Brien, who's a music therapy fellow at Royal Melbourne Hospital. You know, we've had someone send us a message that music is the strongest medicine. I must say, where I was treated, I didn't have access to music therapy. Tell us about its fundamental purpose and perhaps illustrate with how you work with a patient.
So at the start at the Royal Melbourne 21 years ago, they threw open their doors to music therapy, which is extraordinary. And the whole concept behind music therapy is working with the patient in front of you, the person in front of you. It's connecting with who they are. I think often when people come into hospital, and I've certainly heard this over the years, people feel disconnected from who they were. You know, last year they were doing all these other things. They were, you know, picking up their kids from school. They were going to work their whole life. And then suddenly that's gone. And the thing about music, it still connects with who you are inside. We have an extraordinary response to music. You can see this already in the COVID pandemic. You know, people are turning to music more and more. It helps us feel connected. And you know, I've worked with people in deep pain. We actually do work at the end of life as well as active treatment too. And you just see that when you use live music in particular, and the research supports this, the pain is alleviated. It goes away. The focus changes. The brain processes music differently from speech as well. So sometimes if people aren't fully conscious, they can still hear you and you can see little reactions, even as they're coming out of comas. It's quite an extraordinary way to work with people, and obviously, you know, very passionate about creating their original songs, so they have their voice and they can say what they think and feel and get it out.
And that was the study, your PhD study was on
yes,
guided
absolutely.
songwriting.
Yeah.
You know, you mentioned pain, and if I could just speak as a patient, I feel I had great pain management in the sense of opioids and other assistance to deal with the rather tough impact of radiation therapy on my neck. But I had a lot of emotional pain, particularly after, to be honest, when I lost my team. And even now, so I experienced depression and severe anxiety for the first time in my life. Even now, 7 years later, I will use music to modify my mood. Can you tell us a little bit about, is that part of what music therapy will help us learn?
Absolutely. So the thing with using music in your day-to-day life, you know, we can often have that soundtrack, that background to your life. That's great. It's wonderful to do. But really using music mindfully is, I think, what you're talking about there, to modify your moods. And what we do know about music is it can match how you're feeling, but it can also pivot how you're feeling. It can transform your feelings. And as a music therapist, that's one of our roles really, is to find that point of connection, you know, we certainly don't, if someone's really down and flat, we don't go in and go, hi, how's it going? And start singing happy-go-lucky songs, quite the opposite, you know. one of our roles, you know, you can have days when everyone you see, one after the other, people are just crying and letting go. And I'm a big believer of that. You know, have a good cry, let it go, get angry, you know, express yourself. And definitely in mental health as well. You know, at the Royal Melbourne, my clinical program there goes across all aspects in the hospital. And just speaking of COVID, we've been inundated hospital-wide with extra referrals because people are just really struggling mentally, and they want to hear live music. We stay at their door, so we're keeping it as safe as we can. We're not doing any face-to-face contact at all at the moment. We're in the hallways and at the doorways, and the same at Chris O'Brien as well, so people are safe.
I have another music therapist who I want to introduce, but before I do, I want to ask you a couple quick questions, if I may. I understand you've got a staff and volunteer choir, and as I've travelled to different cancer centres in Australia and around the world, you often do see people performing in the foyer.
Yeah.
Can you tell us about that aspect of your work?
Yes, we have lots of choirs, don't we? We have a choir at the Royal Melbourne and also Chris O'Brien Lifehouse. Our choir there is doing really well. And being in the foyers, I think that transforms the hospitalisation experience from the minute you walk in the door. You know, you're coming to a hospital for treatment, you're stressed naturally, or you're coming to see someone that you love, and, you know, maybe things aren't going so well, but you're always in a heightened state. And to actually have live music is one of the things I'm most passionate about. And you hear it as you walk in the door, it transforms, it rehumanises the experience. And it's also great for the staff and the patients and the volunteers to participate in. And in fact, it's going to sound like a shameless plug, but we've just put a song out called Count on Me by Bruno Mars. So we had a thing called Scrub Choir. You can see it on YouTube. It literally came out this morning. So it was on ABC TV, News TV. And it's a wonderful celebration by all our staff and volunteers because, you know, people are struggling all over the world. And it's interesting, earlier you talked about we are concerned that people aren't coming into the hospital. And so the message that we want to send through that song too, so please watch it. You know, it's a moment for all of us to release in the music video, but that you can count on us, that we are going to keep you safe. You know, if you come to the hospital, we have worked so hard, all the hospitals over the last 3 months. I don't think I've ever worked so hard in my life to make sure everybody's safe and that you're welcome and that we'll take good care of you no matter what.
Look, Dr. Emma O'Brien from Royal Melbourne Hospital, and also Chris O'Brien in Sydney, thank you so much. I just want to tell you, one of our former patients has come in and said music has helped so much. And on a recent visit to the hospital, she heard a choir and how fantastic it was. So thank you so much. And I wanted to tell, just as we transfer over to Jack Thomas, who's actually a music therapist at Chris O'Brien Lifehouse. And so we now welcome you, Jack, that if you want to get connections to any of the things that have been referred to by our speakers today, Nadia Rosen, the CEO of Beyond 5, will be putting everything on the Beyond 5 website. There'll be a link on the front page, beyond5.org.au, and you'll be able to see the recording of this program and links to other things. But welcome to Jack. Jack, you're a music therapist. I wonder, we've only got a few minutes and I want to hear your song, but could you just tell us how you think you help people with anxiety? Because I was almost crippled with anxiety when I was a patient.
Yeah, for sure. I think, as Emma kind of touched on quite a bit there as well, it's about how music connects with people and giving people something to focus on. And how it's really a reminder of everything that's happening away from the moment that they're in. So I watched one of the videos on the Beyond 5 website on the emotional wellbeing page. And a lot of people in that video were speaking of focusing on still being them and the same old person and remembering all the parts of their lives that really matter to them. And because music is something that people identify with on such a personal level, it really brings the focus back to that and back to the person. And it's heaps of fun.
Well, if you could sing your song, and then I'll be inviting Nadia Rosen from Beyond 5, who will be thanking everybody. And the words of the song, I think, are available. I'm not sure where they're going to be available, but I think a lot of us know this song. So over to you, Jack.
I think you will. It's a song, I wish I could say I wrote this one, but this is a song by Carole King, or also known to a lot of people by James Taylor. It's called You Got a Friend. And I think one of the reasons I wanted to choose this song, one, because it's a lovely tune, but also, again, following on from what Emma touched on, it's not just about everything's happy all the time. I think this song really focuses musically and lyrically on the difficult times that people have, and then still getting around each other and supporting each other. So sing it if you know it. When you're down and troubled and you need some loving care, and nothing, no, nothing is going right, close your eyes and think of me, and soon I will be there to brighten up even your darkest nights. And you just call out my name, and you know wherever I am, I'll come running to see you again. Winter, spring, summer or fall, and all you have to do is call, and I'll be there, yes I will. You've got a friend. If the sky above you grows dark and full of clouds, and that old north wind should begin to blow, keep your head together and call my name out loud. Soon you'll hear me knocking at your door. You just call out my name, and you know wherever I am, I'll come running, running, yeah, to see you again. Winter, spring, summer or fall, and all you have to do is call, and I'll be there, yes I will. Now ain't it good to know that you've got a friend, when people can be so cold? They'll hurt you, yes, and desert you, and take your soul if you let them. Oh, now don't you let them. Bring it home. You just call out my name, and you know wherever I am, I'll come running, running, yeah, to see you again. Winter, spring, summer or fall, and all you have to do is call, and I'll be there, yes I will. You've got a friend. You've got a friend. Ain't it good to know you've got a friend? Ain't it good to know you've got a friend?
Oh, that was so delightful. Thank
you very
you,
much.
Jack Thomas from Chris O'Brien Lifehouse, where he's a music therapist. I think I would have needed a lot less Valium when I was having radiation therapy if I'd had you in my life. And just before I hand over to Nadia Rosen, who'll close the wonderful first seminar from Beyond 5, I just want to say one listener's viewers come in and said that she listens to music when she runs and it really helps her escape. And Marty Doyle, who's a wonderful patient advocate from Queensland, has said that music helps him to move from a fixed mindset to a growth mindset, and it helps him let go and know that everything's okay. So, Jack, thank you so much for joining us.
Thank you.
And I'll hand over now to the CEO of Beyond 5, Nadia Rosen.
Thanks, Jack and Emma. That was really lovely to finish with that music. And thank you everyone for joining our first webinar today. I think it's fair to say that we put it together in record time, and like everyone out there, we've become experts in Zoom. I have to thank Jackson, who's been our IT support and making sure that this has gone off without a hitch. And obviously all the speakers involved. We wouldn't be able to do anything that we do at Beyond 5 without the collaborative team effort with clinicians, patients and carers across the country. So we're very appreciative of that. And I guess at the core of Beyond 5's work is our commitment to working collaboratively with people, healthcare professionals, patients and family members. And just to give you a few examples of how that happens every day, at the moment we've got about 20 people working to review all of the content that you see on the Beyond 5 website. That happens once every 3 years, and that's an enormous task, and we wouldn't be able to do that. That work is all done pro bono by clinicians across the country and consumers as well. We're putting the finishing touches on a series of nutrition videos that were filmed just before COVID-19 hit, and we couldn't have done that without speech pathologists and dietitians and patients, former patients, being involved. Just yesterday, I had a family member of someone who had a total laryngectomy a couple of weeks ago wanting to speak to someone who had been through the similar experience, and our Victorian ambassador, Mike George, put up his hand to connect with them. Marty put us in contact with a researcher at Queensland University of Technology to see how we can work together to raise awareness of head and neck cancer. We've got Denise Whelan on the Central Coast, who represented us at a local fundraiser just before COVID hit. And Julie, who when I emailed to ask if she'd host this webinar, replied within minutes to say that she would be delighted. So it's just an example of what's going on behind the scenes. For a very small charity, we managed to do a lot, and it's thanks to everyone who's involved behind the scenes and supporting us. So Tracy Nichols from South Australia suggested yesterday that maybe we have another webinar, which I think is a wonderful idea. And perhaps that could happen around World Head and Neck Cancer Day in July. So after the webinar finishes, you'll receive a link to a very short survey. It'll only take 3 minutes of your time. Let us know what you liked, what you didn't like, and if we're able to hold another webinar, what topics you'd like to see on that webinar. That would be really useful, because obviously we need to be guided by you as to what you will find most useful as you're going through your experience with head and neck cancer. So thank you again, everybody, for being involved in our first webinar. Keep safe, take care, and enjoy your weekend. Bye.
Bye. Bye-bye, Jackson.